A very good morning to all of you. Today, my talk will be on Mitraclip, a transcatheter intervention which has come to India recently, and there's a lot of interest in this about how to tackle mitral regurgitation. So my focus is on how does one evaluate these patients who may be eligible for Mitraclip. Now, the question that comes first is why Mitraclip? So the main objective is to reduce significant MR. And who are these patients? These are the ones with heart failure. And these are patients who are symptomatic despite optimal medical therapy. And they are at high risk for surgery. And obviously, they don't have any other option except to go for this transcatheter intervention. Now, what exactly is the procedural objective of Mitraclip? It's fairly simple. The idea is to introduce a clip, a device. This is pushed across the interatrial septum into the left atrium, as you can see over there. And next is it descends down into the ventricle just below the mitral valve. And there it is positioned and the clip is put in place, and then the regurgitant orifice which was there is now closed. So once it closes, you can see that there are two orifices, and this is how the whole thing functions. And on the 3D, this is how it looks. Now, a brief overview of mitral valve. So this is how the imaging looks like. The quality of the 3D images has improved remarkably over the last year or so. So this is from the LA side. You can see the antemitral leaflet on top and then the posterior mitral leaflet below. And this can be better read if you have this clock. So you have the 12, 3, 6, and 9 o'clock. So what does it mean? So you have at 12 o'clock the aortic valve, and then at 9 o'clock there is the left atrial appendage, and of course the tricuspid valve is just some sort of anatomical landmark over there. Now, if you look at it more closely, these leaflets are further sort of segmented. So starting with the posterior mitral leaflet, you have the P1, P2, P3, and the corresponding A1, A2, A3. So this sort of sums up how one can look at mitral valve. And of course, when there is mitral regurgitation, the objective is to look at where this regurgitation is coming and how many jets are there. So this is to sort of compile reasonable information of what is the status of the mitral valve and the regurgitation. So how does one go about screening these patients for whether they are having significant MR, and what are the other anatomical sort of findings which are in favor that they can be thought of as patients for Mitraclip? So the transthoracic views are just the routine ones. There is the parietal long axis, the short axis, apical views, subcostal views. And a point I would like to emphasize here is use the zoom view as much as possible, especially when you're looking at the structures, when you need to look at it more closely, and also you need to make small measurements. And whenever the jet is being looked at, it is always better to have a color comparison. That means you have the 2D on one side and then you have the color on the other side. So starting with the parietal long axis, there is the posterior mitral leaflet. So this is the important leaflet here. The length of the leaflet has to be measured. And then again, looking at the leaflet thickness, so whether it is myxomatosis, whether it is a fibroelastic deficiency, or there's rheumatic etiology. And then the leaflet calcification, so whether it is there or not. If it is there, where is the location? Especially the focus is on the A2, P2 area. That is where the clip is going to be. So a lot of sort of focus should be there. Then it is important to look at the left ventricular size. So again, a very large LV again precludes the possibility of Mitraclip being put in place. So it is not favorable if the LV is more than 65 millimeters. And then the other approach is to look at the mechanism of the MR. So again, here it is very important that we identify what is the cause for the MR. So as all of you know that there is this Carpentier classification, again, just sort of a nice slide which sort of summarizes everything here. So there is a classification of the primary MR and then the secondary MR here. Then you have the Carpentier type 1 and then the Carpentier 2 and then 3A and 3B. So let's look at primary MR here. So here the leaflet motion is normal, and this is where most of the times it's a perforation because of an endocarditis as an example. And then you have the excessive leaflet motion. So here the example is mitral valve prolapse. And then the third one is the restricted leaflet motion, and this is the rheumatic valve disease. Coming to the secondary MR, the type 1 is where the dilatation takes place. So it could be because of atrial dilatation, or it could be because of ventricular dilatation. And then you have the 3B, where the ischemic cardiomyopathies, and this is more often the tethering of the leaflets. Now, next is to look at the structures in the short axis. So the focus here is to look at the interatrial septum. So mainly to look at possible problems that can cause, that can influence septal puncture. So examples are atrial septal defect, small ASDs which can be there, or maybe a device has been put in place, or a previous surgery has been done, again, which is not possible for Mitraclip to be done. Then, is there a patent foramen ovale? Is there a atrial septal aneurysm? So these are the abnormalities which one needs to look into. Then there is the mitral valve level. So here the leaflet calcification is again looked at, and then there is the location. So here it is much more easier to find out where the location of the calcification in the short axis. So a lot of attention, a lot of zooming has to be done here. And again, as much as possible, it's subjective, so the severity also. Then the mitral valve area, again, as per standard protocol. And then the jet origin is very sort of nicely seen here. For example, here you can see that the jet is coming from the A2P2 area. So this gives us information about various findings which need to be put in for understanding of what is happening to the MR and the mitral valve. Next is to look at the apical views. So the apical views, again, we have to go through the sequence of looking at calcification, location, and severity. By this time, we have a fair idea of what the calcification, whether it is there or not, and the location and the severity. So, but we have to go through these various views so to get a complete picture. And once you have done that, then the mechanism of the MR, again, to a large extent, again, by this time, you know what exactly is the mechanism. It is just something like a conclusion of what you've already seen. And then the jet origin. So looking at how the sort of jet arises. So is it a single jet, a jet direction, multiple jets? So all these things should be looked at in the apical views. Then the MR severity. So this is again as per standard protocol, just like any other guidelines we have to go through. So the main points I have highlighted here. So one is to look at the vena contracta, and then the other one is looking at the PISA, where you can get the effective regurgitant orifice area, and then the volume also is there. And then there is the peak E velocity. So the E velocity, the more higher the E velocity, more than 1.2, 1.5 meters, that means the MR is significant. And then the gradients, higher gradients, more than 5 millimeters of mercury of mean gradient is not favorable for Mitraclip. Then looking at the pulmonary vein, especially the S wave, is there blunting, is there reversal? So that tells you what is the severity of the MR. Then the last part of it is the chamber function analysis, again using standard methods of Simpsons to look at the LV systolic function, the LV ejection fraction. RV function, you can use any of the methods of TAPSE or the tissue Doppler. And again, severe RV dysfunction is again not favorable for Mitraclip. And we also make sure that other pathologies are not missed out, and they can have an impact on the Mitraclip decision making. So, for example, if there's significant aortic and tricuspid valve pathology, that's a problem, and also any other abnormalities, again, which may influence Mitraclip decision. And then lastly, to look at the pressures, both the right atrial pressure as well as the pulmonary artery systolic pressure. And then you have this checklist, which you can have. You can sort of tailor it for your own sort of approach. And this sort of summarizes. And then from here onwards, we move to the TE here. So TE is primarily, at this point, you've decided that this patient has got mitral regurgitation. Now it's a question of eligibility. Is this patient eligible? And if this patient is eligible, how can we plan the Mitraclip? So here the views are the 4-chamber views, and then the bicaval and short axis. The focus is on interatrial septum, the mitral valve, the MR jet, and also additional views and additional structures and parameters. So starting with the 0 degrees to 20 degrees, so to look at the interatrial septum, so this is the 4-chamber here. And this is to look at the puncture height. So to look at this, to get a good measurement, the valve has to be closed when the measurement is being done. The ventricles have to be in full length, no foreshortening, and they should not be LVOT, that is viewed. So that means you should not have a 5-chamber view. You're too high. And then the maximum length of the fossa vallis should be attempted to get it so that you can get a good measurement. So at least a minimum of 4 centimeters is required. So anything less than that, again, is not favorable for Mitraclip. So that is the objective of this view. Next is to move to the bicaval and then the short axis view, again to look at the interatrial septum, but for a different purpose. Here you're looking at it for any pathologies of PFO, ASD, atrial septal aneurysm, and also to look at the nature of the septum here. Is it thick? Is it thin? Is it going to be good for punctures easily or difficult? And again, location and length of the fossa vallis. And here, the availability of the X-plane or the biplane in the present-day machines is invaluable. So where you can simultaneously look at the bicaval as well as the short axis here, which is reversed here. So this is something which is very, very important. So it's just a comment here that if any Mitraclip is being attempted in your institution, it's very important that you have the highest end of the machine. So a middle end or anything less than that is not really a good way. So I think that really won't work out. Then after looking at the septum, now it is the turn of the mitral valve here to look at the intercommissural view starting from here. So to look at the various segments here, and it's very important that you have the P1 and P3 having the same length. So that means you're sort of well angled here. And also ideally the papillary muscles should be seen. So this sort of gives you how the intercommissural sort of view is cut across the mitral valve when it crosses the 3 segments of the leaflets. Next is look at the mitral regurgitation. So here the views again, starting from the intercommissural view. And then the next important view for the mitral regurgitation is the long axis view or the LVOT view. And this is the grasping view. So for the long axis, ideal one, it has to be orthogonal to the intercommissural view. So that has to be 90 degrees. So for example, if you've got an intercommissural view at 60 degrees, then your long axis has to be at 150 degrees. So that means you're looking at it 90 degrees angle, that is the orthogonal view. So this is something which you have to keep in mind. Next is to look for the jet itself. So search for the biggest jet, and if it is not viewed, you advance or retract the probe and then turn clockwise or anti-clockwise, and also look for the mechanism of the MR. So you can see that the MR is coming from the A2P2 area here. So this is there are multiple jets here coming from the commissures as well as the A2P2 area. And this is the long axis, the LVOT view, which is seen here. Now, once the biggest jet is identified, next the focus is on to get the meat of the jet or the center of the jet. So the jet has to be carefully investigated. Now, it is very important that you get the center of the jet because this is where the clip has to split the jet and the orifice will be symmetrically sort of closed here. So this is how the central jet, and this is the cursor which sort of tells you, gives you a marker that you're in the center, and this is the orthogonal view here. So make sure that to use this to get the center of the jet. And then look at the leaflets at this point and see what is the mobility, the quality of the leaflet here, and the strength of the leaflets here, or any calcification. Next is to look at the medial edge of the jet. What is the extent of the jet to how far it is extending? So as you can see here, the arrow has moved closer to this side of the segment. And this is just to investigate to what is the extent of the jet. So for this, you have to turn the probe clockwise. So that means you go nearer to the A3P3 area. And this is again with the cursor. And that is how you can see the jet on the other side also. And you go through the same sequence of looking at the leaflet investigation here, looking at the various parameters to make sure that the quality of the leaflet is good or bad. And then the next is to look at the lateral edge. So that means now you go in the opposite direction. Turn the probe anti-clockwise here. And you go to the other side here. That means if you look at the arrow here, you're going towards the A1P1 area. So this is the anti-clockwise direction. And again, the mitral valve is investigated in the same way after the color is taken away. So that is how the 2D approach is there for investigation of the mitral valve and the jet. But now with the advent of 3D, it makes our job much more easier. So these are various examples of how the jet can be sort of localized. You can see that the jet is coming from the A2P2 here. And then you have these multiple jets. So they are coming from the commissures. There's a central jet here, another jet from the commissure. And this is from another patient where the jet is coming from the A2P2 area. This is a central jet. Also, with the availability of the true view and also the dual image, you can simultaneously look at the left atrial side as well as the left ventricular side of the leaflets, and gives you a fair idea of what is happening to the mitral valve. Then the severity of MR is investigated, just like the transthoracic. So there is the PISA here. You have to do it the full complete way. And then the mitral wave peak velocity, the vena contracta, the pulmonary vein flow. So these are standard parameters, minimum parameters, which you have to go through. And in case if there are some additional information which you need to require, there's always something which you can take, and then you can sort of move the probe to 5 chamber, or you can go a little lower down. So you have this high, mid, low esophageal level, and also to look at the mitral valve in different views also. So this is something which you can always fall back. And then additional views, transgastric. So once you push it into the stomach, so the idea is to look again at the jet sort of where is it sort of arising. So here you can see that the jet is coming from the A2P2 area. So this gives a good idea of how reliable your earlier interpretations have been. So the origin of MR. Again, in the transgastric, additional information can be obtained in terms of valve area here. So the planimetry can be done and the information obtained. And this is another way of looking at LV function, RV function. Of course, you can use the 4-chamber also to look at LV function, RV function. Then additional parameters, one can look at leaflet thickness and calcifications, zoom view for here. And then the LV size, again, this is just one view. You can look at it also in the transgastric view. And then the leaflet length is there. And then the mean gradient also to be obtained at this point. And it's important that when you're looking for eligibility, you have to make sure that there's no LA thrombus, there is no previous ASD surgery, an IVC that is abnormal in whatever ways, and then pulmonary hypertension, which is very severe and due to other causes, maybe that has to be investigated, significant aortic and tricuspid valve disease, any of the findings which may impact the Mitraclip decision making. So lastly, coming to the last few slides. So this is the primary MR here, and a few sort of points when it comes to primary MR. So here you have the degenerative valve, so they are more likely to prolapse and have a flail. So here the Mitraclip can be done, provided the measurements are within the acceptable limits. So this is the flail gap here. So flail gap is better seen with 2D. And this is the flail width, and this is better seen with the 3D, but if, this has been shown from the transgastric, a little difficult, but I would encourage that you use the 3D much better to get the flail width. So this is for primary MR. For secondary MR, the focus is on a different set of parameters. So the focus here is the coaptation depth. So this is the base where the annulus, this is the baseline here, where the annulus plane is. And then from here, if you measure from this point to this point to the coaptation, this is the coaptation depth. And a small bit of tissue which sort of projects out, this is the coaptation length. And this is again zoom view, and this has to be measured. So what are the important measurements that you have to keep in mind? So you have the coaptation depth, which has to be less than 11 millimeters. So all these parameters which I've listed here are important for successful outcomes. So they have to be less than 11 millimeters here. Length of the coaptation should be more than 2 millimeters. Septal puncture height should be more than 40. The PML length, minimum 7, ideal 10. Mitral valve area, always good to have more than 4. 3 is again a tricky one, so decision making is required there. Mean gradient maximum, you can push it up to 5. After that, it's not a good idea to go ahead with it. Flail width, it should be less than 15. Flail gap less than 10. And then, of course, a large LV also is not a good thing, so it should be less than 65 millimeters. So sort of this is my closing slide. So just sort of a take-home message. So who sort of benefits the most? How does one choose the optimal patient? So this is a nice table from Jack. And here you have the optimal, the conditional, and the unsuitable ones. So the ideal one is A2P2, no calcification, valve area more than 4, and mobile length of the PML should be more than 10, and then the coaptation depth less than 11, normal leaflet strength and mobility, and the flail width less than 15, flail gap less than 10. And of course, when you have unsuitable, so all these, if it is severely calcified, very small orifice, short PML, and very restricted leaflet, and then multiple segments, especially in degenerative valves, is not a good finding to have to take a decision on Mitraclip. So this is the take-home message, and this is how one can assess both by transthoracic and transesophageal echo to identify patients for Mitraclip. Thank you.